some of these bills in the States, this is at risk, which to me is absolutely inhumane. Compounding is critical healthcare infrastructure. Compounding is necessary for a lot of people who have allergies, sensitivities, unique circumstances where they just can't take the FDA-approved medication. And laws that would restrict or shut down compounding, it is so cruel to so many patients around the United States. It is critical.
You're listening to the GLP-1 Studio Podcast.
Today I'm sharing an interview with one of this community's favorite people in the whole world, Sabina Hemmi, known as Lollipop on socials. Sabina is a patient who was frustrated by the endless funnels just to see a cost and the deceptive pricing. So she built the solution. GLP Winner is a transparent comparison site where you can actually see what you're getting before you type all of your information in. This tool has been absolutely invaluable for patients who are desperate to find affordable options and afraid of finding a sketchy option instead. Sabina has become one of the most trusted voices in this space for patient education and advocacy. Today, we're discussing the state and federal bills that are threatening access to compounded GLP-1 medications. If you are a patient or an ally for access, thank you for listening because we need your help. And Sabina is going to tell us all about it. Without further ado, Sabina Hemmi. I've been following you and trying to stay on top of the new bills that are coming out. And I was just about to release this article about these new bills. And then I saw last night, there's another one. Is it Massachusetts?
There is a Massachusetts bill. It's resurfaced. It was around last year. The Massachusetts is like a different shape than the other bills because it's old, is what I'll say.
Okay. Yeah, I was like, I need to add this one too, and let me get Sabina on this article. First, let's introduce you. Tell us your full name and what you do.
Hi, I'm Sabina Hemmi, the founder of GLP Winner, which is the comparison site. If you are looking to get on GLP-1 medication, we're trying to be a neutral place where you can compare all the options rather than just seeing ads that have deceptive pricing or going down a funnel where you're going to take 15 minutes, give them your name, email, phone number, full medical history, like just to see a price and realize it's too expensive. We're trying to shortcut all of that and have one transparent place where you can compare providers. If they're doing compound, you can see how much they cost. If they're doing name brand, you can see how much they're going to cost, and ideally route people to safe, affordable options. Because when we're paying hundreds of dollars for medication, we need to be able to budget around it, right? So that's kind of my way of fighting back on the system and being unhappy. I had a situation where I was on compounded GLP-1, and this was a while ago, right? And my provider, which was like an in-person local OBGYN who had a weight loss clinic, changed compounding pharmacies. And then their price went from, I can't remember what it was, like $500 a month to like $800 something a month. And I was like, that's BS. I know I'm getting screwed. I know you're literally charging me the highest price you possibly can without me going to name brand at that point. This was like back during the shortages. So I had it on my to-do list, like, let me go find other options, but it was just so painful to compare them and shop around and all of that. So that's why I ended up making the tool, because I was so annoyed by my personal situation. I'm a patient too. When I got started, it was honestly presented to me as something I would be on temporarily, which is now considered outdated, but that's how my prescriber, presented it to me. And I knew within the first month or two, I was like, I want to be on this forever, even though my side effects were horrible. I was like, I want to be on this forever, but like side effects are no joke. Like I might take breaks. I didn't know what that looked like yet. So for me, then it was, how can I budget around being on this forever? Because I don't see my insurance paying for it anytime soon. And for most people, their insurance doesn't pay for it. So that's somehow how GLP Winner came to be.
I think that patients make the best stuff because we know from experience. I'm talking to all these different companies that are like, what do GLP-1 patients want? But we know.
Yeah, we know. And to be honest, this isn't my first company. This isn't the first thing I built. And I was looking to start a company. I wanted to do something in healthcare. I started with a completely different idea, met my co-founder and moved to this idea and launched a prototype really quickly. But my previous idea was around, and there's a lot of companies trying to do this now. So technically you should have access to your medical records, right? I would highly recommend, if you ever have a health crisis or like a short hospital stay or whatever that looks like for you or your loved ones, go request your medical records. Sometimes that means you have to go in person, pay money, like $30 to $100 for them, but you will learn a lot from looking at your medical records, because if you've never seen your full medical records before, you probably have diagnoses that you had no idea that you had. So if you stay in the hospital, 4 days or something, you're going to go through your medical records and you're going to be like, that's what they gave me. I can go look up that medication. Oh, I have this diagnosis, but they didn't tell me because it was just a minor thing. And maybe somebody assumed that I already knew I had it. There's going to be a lot of new information like that. So what we were trying to do is create a tool where patients could have their medical records all in one place, and then, potentially use AI to help understand things that they didn't know and contextualize things that they didn't have information for, or that the doctors didn't have time to explain to them, because our doctors don't have time to explain stuff to us. And we were sort of targeting people who have really hard to diagnose things like chronic illness, autoimmune disease, things that are more complex and harder to manage. And now there's a bunch of companies trying to do stuff like that. I haven't seen one fully take off yet, but I'm still obsessed with that idea. I just ended up building this one instead.
I love that idea. I didn't even think about the AI aspect, but it could be so helpful for just making it in layman's terms so you can actually understand what they're saying.
Yeah. I mean, so often doctors don't actually explain things to you. And if you've never seen your full medical records, you probably have diagnoses that like you might have like psoriasis or something. And like no doctor ever said that word to you. So you didn't even know to go educate yourself on this thing that you have.
You always have this empowering angle. You're like, how can I help people do something? I
Yeah.
love that. You're not just like, how can I make money off of people? It's how
No.
can I help people?
Well, my last company was in video games, and totally different, but exactly the same. It's like data and analytics for video games. So you imagine people play online multiplayer games that generates a bunch of data. We take that data and try to get actionable insights for normal people. And, that company's been around a while, so we do a lot of other stuff, but that was always our core product of like information that's hard to bring it together, and make it helpful and useful for people.
As a video gamer, I appreciate that. And I did check out that tool and it's amazing. It's amazing. You are amazing. Oh my gosh. You have the coolest ideas. You're one of the very first people in the GLP-1 space that I connected with. And it's because you saw the petition, right? And you reached out to me.
Yeah.
Did you know at that time that we would be here like a year later fighting together?
I mean, I think after we spoke, I knew we'd be friends for
Yes,
as long as we were
definitely.
talking to each other, really. And yeah, I knew I would be here fighting. I knew. So I'm not surprised,
Well, I'm grateful for you. I really am. I think that if it weren't for you, I'm not sure that we would know about these bills.
which
I'm
is
not sure
scary.
that we would be informed. It is really scary.
Yeah, the mainstream press is not covering this stuff. And sometimes even like I talk to a lot of telehealth companies because of my work, right? And a lot of them aren't comfortable. I'm like, hey, you should email your patients and let them know what's going on if they're like in one of the states impacted. And a lot of them are like, well, I don't know, privacy issues, whatever. It really isn't a privacy issue. It isn't a HIPAA issue. If you email patients in a state, it's really like your patients would like to hear from you if they're at risk of losing access to treatment that you're giving them, right? But
Yeah.
I think a lot of people are hesitant to, unless maybe it's further along and it seems like it's going to pass. I'm not sure. It's much easier to kill bills earlier.
Yeah, before it gets started. So let's talk about the bills. And again, thank you so much for reporting on these.
There's the Federal SAFE Act, which is House Resolution 6509. That came out. And what's weird about this federal bill, and first of all, I'll say with the state or our government, the House isn't going to be passing a lot of legislation unless people are just really excited about it. I think our government's going to shut down again. If this passed, it would probably be a year if it passed, right? So it's not like an emergency like some of the state stuff, but it was presented. And of course, it's brought in by two representatives in Indiana, which, if you don't know, Indiana is the state where Eli Lilly is located. They are the largest employer. They have a lot of influence in that state. And what's interesting is when you read the summary that they put together, it's like, we're putting an end to mass compounding, is the vibes of the summary. You read the bill, and honestly, it's like very confusing. Most of these bills, when you read them, are very confusing unless you really know pharmacy law. They're often written to be confusing. And if a layperson or, a legislator who's not a pharmacist, which is almost all of them, reads it, they're like, oh, okay, I don't understand what this does, but sounds good. It's about safety. And no matter what, it's really important to say, no matter what happens in healthcare with policy, everything is always going to be argued from the angle of safety. So you should know up front, everything is always going to be framed as about safety, whether
Oh,
it's
that name
actually
is
making this
cute.
stuff. Yeah,
The Safe Drugs Act. How cute.
yeah. Yeah, the Safe Drugs Act, right? Like, and some people who are less into the weeds as me, like read that, they're just like, well, I don't know. I like safety. Like, why would I oppose this? It doesn't make any sense, right? And I think in a lot of ways, the federal bill is there to help the state bills get through, to be like, hey, there's a federal thing. Like, this is a big problem. This is a big trend. You need to be taking care of this.
I see. That's a good point. I didn't think about that angle. So let's describe what it does for the people who are not going to go look into it themselves, that just want to listen.
Yeah, the Safe Drugs Act, what it does is it sets a lot of definitions around essential copy, how many copies. One of the big changes it does is it has all the pharmacies reporting the number of prescriptions that they have. And what's interesting is the Obesity Action Coalition, which is a pharma-funded group, is supporting this bill. When you look at their statement around why they support this bill, because they released this, I think because I made a TikTok saying I didn't like this bill. But when you look at their statement, they're talking about like, well, we need to be able to track how many prescriptions are going out because of adverse events. We need to be able, like, if somebody has an adverse event, we need to be able to like figure out where the adverse event was coming from and like all of this. This has nothing to do with adverse events. So like an actual safety improvement I would support is 503A pharmacies reporting adverse events to the FDA. Now, practically, because I change providers every month, I do reviews of them. I've gotten medication from a lot of pharmacies in the last year. Most 503A pharmacies will literally put a piece of paper in your prescription, or sometimes on the prescription label itself. It will often say, like, contact the FDA if you have adverse events. Here's the phone number. Here's how you do it. Right? But they are technically not mandated to report adverse events to the FDA. 503B compounding pharmacies are. You don't really need to know the difference. They're just two different types of compounding pharmacies. But it has nothing to do with adverse events or adverse event reporting. It wants them to report number of prescriptions. Why would pharma want to know number of prescriptions? For litigation, so that they can better demonstrate what they perceive as mass compounding, so that they can also better claim damages, right? And so far, and this is a way oversimplification of the litigation that's going on, so far when pharma has been suing telehealths and compounding pharmacies in the space, by and large, it has not really been successful. And why it hasn't been successful is sometimes because they don't have hard numbers. They don't have hard numbers in damages. So it's like, what does it matter? But oftentimes it's, can a private company, like a pharma company, sue another company in the space with claims that they are violating a law that is regulated by the FDA? So things like, if, say, Eli Lilly, which they probably do believe this, but I'm not going to speak for them, thinks that mass compounding is going on and the way that compounding is currently occurring is improper and shouldn't happen, and they want to shut it down, right? They could sue on drug patent because they have a drug patent, but they don't want to do that because it has too much risk. But they're suing on like marketing and all these other things. And they're often citing, hey, these things are being improperly compounded. Like, they should not be compounded. But when you put that before a federal judge, oftentimes the judges are saying like, hey, that's for the FDA to decide, right? Like, a private entity cannot sue on behalf of enforcing a US law. They have to show that they have like direct harms from the other party and that they're like functionally competitors. And that has mostly not been proven so far in litigation. And many of the cases have been dismissed. Now, the resubmitting litigation, it's always evolving, like that's an oversimplification without going lawsuit by lawsuit. So what the Safe Drugs Act does is it helps give them numbers for that. And it also does a lot of definitions around mass compounding, et cetera. A lot of definitions that kind of already exist. And by defining them in law rather than having the FDA define them, what they're trying to do is take agency away from the FDA. Because the FDA is the one who regulates what compounding pharmacies can compound or not. And they regulate and do enforcement on, is mass compounding that's inappropriate happening? And they enforce that. But they have not, as far as I know, enforced that for GLP-1s. So the FDA knows what's going on and it hasn't done anything about it, which tells me, I guess they're okay with it, right? Like, I don't know, right? I guess the FDA is okay with it because the FDA will literally go inspect compounding pharmacies, see that they're making GLP-1s, and then be like, great, you passed inspection. And
I think that there's a really interesting comparison that can be made here. I can't remember the name of the drug. Lord help me. There was a drug for pregnant women that was compounded for a
Mhm.
decade, and the FDA allowed it to continue happening. They didn't want it to happen, but they did not enforce them to stop letting it happen. And women were allowed to ask for this compounded version for a decade because it was too expensive. It was too
Yeah.
expensive. And so, for the sake of affordability, they let pregnant women have compounded medication for over a decade. And when that medication came off of the market, it was not because it was unsafe, it was because it didn't actually work. Like a decade later,
Oh,
they were like, oh, this isn't actually doing anything. Let's just stop making it.
yeah.
But the FDA allowed that to happen. And that is what I think is happening now. And I sent 2 letters to the FDA using that comparison. And I was like, look, you guys let compounding happening for 10 years for these women. You weren't afraid about safety then. So we need affordable access. And that's what I think is happening now.
Yeah. I mean, the FDA knows that if compounding went away, a lot of people would go to research peptides, which is less safe because you don't have a doctor in the loop. You don't have a doctor monitoring. You don't have a doctor giving instructions on how to dose. And I understand why people go that route. I don't judge people who go that route, but I think we should have affordable options that involve a doctor.
Absolutely. Safety first. And I feel exactly the same way. People should not be forced to go a unsafe route when there's a perfectly safe option that involves healthcare providers. For anyone who is just catching up, because I think that we're going to get a lot more people in the loop on GLP-1s when they're available through Medicaid and Medicare, and people are going to be curious about what the story is. So we went from people trying to lose weight and stealing Ozempic from diabetics in the news, right? That evolved. And we've learned that that's not exactly what was happening at all. But what happened after that? Why is pharma suing all of these compound pharmacies? I think that we should give some backstory there.
Yeah. So, how GLP-1 compounding got started was that the drugs were in shortage. They were more popular and not available. So I spoke to tons of patients. I spoke to one patient who couldn't fill their prescription for a year from their local pharmacy. I spoke to other patients who started out not on the lowest dose. And if you're not familiar, like typically like the standard pharma dosing is that you start at a dose, you go up and dose every month. And when you go up faster than you need to, or if you started at a higher dose, that's actually really risky, that you're more likely to have serious side effects. You're more likely to, be really uncomfortable as a result of that. I've spoken to multiple patients who started not on the lowest dose, which I don't think is very safe because of the shortage. Yeah. And so compounding pharmacies do 2 things. I can explain I guess I can high level explain what a compounding pharmacy is. So when you think of like a normal retail pharmacy, Walgreens, CVS, Rite Aid, they take medication that has been manufactured and they distribute it, almost like a grocery store sells a bag of chips. Compounding pharmacies, they actually make medication, they customize medication, and they create medication when it's not available or in shortage. And so think of it more like the deli counter at the grocery store, where it's like actually being made at the grocery store. That's closer to our compounding pharmacy. And 100 years ago, most drugs were compounded, right? Most pharmacies were custom making a lot of drugs. And a classic example of, a compounded drug is a kid can't swallow a pill. And so you crush up the pill, you add cherry syrup to it, and that's what you get. So a lot of us who grew up getting like bubblegum flavored antibiotics as a kid, that was actually compounded in the doctor's office often.
No.
Right? Iconic flavor. But you've most likely had compounded drugs or will have compounded drugs sometime in your lifetime. Compounding also exists and is really valuable for veterinary care. So you imagine there's a lot of medications that work well for humans, but don't come in a variety of different pill sizes. And what a horse needs and what a 10-pound chihuahua needs, totally different doses, right? And you even just look at the variety of dog sizes, totally different doses. So a lot of veterinary medicine gets compounded as well. Some of these bills that we will talk about today impact all compounding. So the kid who can't swallow a pill, our cats and dogs getting medication. A really common veterinary one is like cats who really, really can't swallow pills and they absolutely need a medication. Compounders can compound it into something that you put on the back of their neck and they will still absorb the medication. Right? So for some cats, it's like that's the only way they can get treatment because they will absolutely not tolerate a pill. It also gets often used in dermatology, custom like skin things. If you have really sensitive skin, you can get medication compounded to not have alcohol or other preservatives. And it gets used a lot for geriatric and end of life. So you imagine somebody who's on hospice, maybe they can't swallow anymore, maybe they don't have an IV, maybe medication doesn't come intravenously. Compounders can put a tincture of, say, like opioids or pain relief that then they can put in their mouth even when somebody can't swallow a pill, and somebody can still get pain relief and palliative care at end of life. And some of these bills in the States, this is at risk, which to me is absolutely inhumane. Compounding is critical healthcare infrastructure. Compounding is necessary for a lot of people who have allergies, sensitivities, unique circumstances where they just can't take the FDA-approved medication. And laws that would restrict or shut down compounding, it is so cruel to so many patients around the United States. It is critical.
Yeah, man, I'm really glad that I asked you to give that overview because that was way better said than I would have said it. Those were some really good analogies that like I think can really take people there. So thank you for sharing that.
Yeah.
Now, the Safe Drugs Act, am I right in that a compounding pharmacy, if this goes through the way that it is without changing, could only dish out 20 prescriptions a month?
Possibly. It really depends on how you read it because it's redefining some of the definitions around essential copy or not. And it's like, it's written by pharma. We know how pharma feels about essential copies. They think that most GLP-1s are essential copies in mass compounding and they don't like it and they want it to stop, right? But a lot of these laws, they look bad. We won't fully understand how bad they are until they're in practice and we see how they're being enforced or not enforced. So the Safe Drug Act, I'm not a fan of. Yeah, it limits essential copies to a ridiculous amount, which is 20 per pharmacy. And some of these compounding pharmacies, they might do 10,000 prescriptions a day or more. Some compounding pharmacies are small. They're like mom and pop corner stores. They're like your very, very local pharmacy that customizes medication. Other compounding pharmacies are large licensed drug manufacturing facilities that also happen to do compounds, quite literally doing, tens of thousands of different medications per day, and they're critical infrastructure. Most hospitals have compounding pharmacies in the building or use compounding pharmacies all the time. I'll give you a quick example. Like every hospital has like a crash cart. Maybe that crash cart has like epinephrine, Benadryl, morphine, like common medications. Compounding pharmacies will pre-fill them into syringes in a way that will divide up a vial of medication across more places. Because otherwise you would get to use the vial once, it would still have medication and you'd have to throw it away. So it prevents waste. Theoretically, it reduces the cost of healthcare, but the hospital's still charging us a bunch anyway, right? But it saves hospitals money, and hospitals all the time use compounding. But there is this weird stigma around compounded GLP-1s. I have a lot of theories as to why that is. I'll give you an example. Mayo Clinic uses compounding pharmacies. The doctors have no issues giving a compounded prescription for like a lotion or cream or like any other thing people have, but they don't prescribe compounded GLP-1s. And when you think about it, why would a top hospital like the Mayo Clinic, a top research hospital, want to keep friendly relationships with two of the larger pharma companies, right? Because there's a relationship between research and pharma, because pharma pays for a lot of research, pharma acquires a lot of research. And so it's critical that large hospitals who might participate in research keep friendly relationships with pharma.
That's a really interesting point I did not think about.
Yeah. And here's the other interesting thing to think about. You went to Obesity Week, the Obesity Society. So imagine you're an ambitious doctor who wants to do obesity medicine. Maybe you dream of being on the board of the Obesity Society, which is like one of the top obesity medical organizations. You have to say that you're anti-compounding to get in that room, right? So there's this pressure from ambitious doctors who kind of conform to the mold, which is most doctors. Most doctors are kind of goody two-shoes, let's be real. It's what made them go to school and learn the ways you had to do things. It's how success was measured for them. So it attracts a certain personality. But they can't be pro-compounding in any way. And at Obesity Week that you went to a couple months ago, or I can't remember, it was October, November, they didn't allow any research on compounding. So they had a bunch of research papers there, no research on compounding. So then the doctors who can not like compounding can continue to pretend to basically say, yeah, Not enough research is done. We actually don't know if compounding is safe or not, right? It's like pulling the wool over their eyes and being like, we don't know if compounding is safe or not. But we've seen a lot of larger telehealths come out and their research seems to be kind of consistent with name brand medication as far as outcomes and safety. Even the FDA published some adverse events for compounding and they straight up said, adverse events for compounding are similar to adverse events for name brand. So there's not a major difference in the adverse event reporting that they're getting.
You bring up a lot of really good points. Is there anything else that the Safe Drugs Act is doing before we move on to the next bill that we have
Nothing that comes
not
to
covered?
mind. Nothing that comes to
Okay.
mind, but I'm sure I will like afterwards be like, oh man, I should have said this. Right.
I'll put it in the article.
Yeah.
Okay, so which one came out next? Was it Florida or Indiana?
Can we lump these together because they're all very similar? I can talk about some differences, but honestly, I'm going to repeat myself and be boring if we
Throw them all
go
together.
line
Let's
by line.
go.
Okay, so here are the bills. There's Indiana SB 282, which positive update. It got amended. It's mostly, I could nitpick. I'm not happy with a couple things in it, but it's mostly fine now. And it just passed into the House, passed out of the Senate to the House, so it's likely going to pass. Virginia HB 917, which has been delayed in committee. They're going to bring it up next year, so delayed a year, so no longer a threat. For this year. There is Washington HB 2613, which just went to committee Friday, January 30th. I watched some of the testimony, not all of it. And what's weird is I expected it to be voted on committee. They just didn't vote on it. So it's in limbo. It'll probably come up in another committee meeting. And there's Florida Bill SB 860 and HB 877. One of those was early. The other is kind of a House companion. And then there's Mississippi SB 2542. The Mississippi one is fairly new. Many of these bills kind of do the same thing. I'll say, I think it's Florida HB 877. I could be confusing the Senate and House bill. Washington HB 2613. And it was very similar also to the initial Indiana bill. These bills effectively shut down all compounding. The Indiana bill started out that way. It got amended to just be GLP-1s, and then it got amended again. But as I spoke about when I was talking about the basics of compounding, you are taking medication away from people where they currently have access to medication. If you take away compounding, they will no longer have access to medication. That includes people in hospice who are in a ton of pain and suffering, not being able to have care that they could have had at end of life, which to me is completely unconscionable. That includes lots of people who have allergies, specialty medical situations where FDA-approved medication doesn't work. Or sometimes FDA-approved medication comes in a really high dose and a medication is being used for something else, but they need a really small dose. And so compounding gets used to make sure that it's dosed out correctly, right? All these kinds of use cases would functionally be shut down with many of these bills, including the Florida and Washington one. I think the Mississippi one too, but I would have to double check that because it's been a minute and there's like 10 bills and they're all very, very similar and they're all like kind of copy paste, but then the reps add in a little flavor of their own. So
what happens if one of these bills, hypothetically, without changing, let's say Florida did not get amended, it got passed, what would happen if Florida could no longer compound?
If Florida could no longer compound, of course, there would be the negative impact to all of the residents of Florida. They would not be able to get compounded medication from out of state. But I will also say Florida is one of the largest compounders in the US. So I think if you are currently getting a compounded GLP-1 and this Florida bill goes forward and compounding pharmacies shut down, you're probably going to have delays getting your prescription filled. So it impacts all of us. And then never mind, if any of these bills go forward, it sets precedent that makes it easier to pass them in other states.
Would you say that this is a coordinated effort through Big Pharma to shut down compounding?
Yeah, obviously. It's
specifically for GLP-1s.
Specifically, yes, but some of the bills are broad. What's funny is the Washington bill shuts down all of compounding, GLP-1 or not. But then, like, funnily enough, in certain points, it says weight loss. And you're like, why would this say weight loss? Oh, because you messed up your copy-paste job. Like, that's it. That's it, right?
No.
Yeah. And what's funny is, like, in Washington, I'll use Washington as an example because they just had a hearing yesterday. It's a House bill. And I guess Washington State has like really small districts. Like I looked up some of the campaign finance information. These legislators were getting like $1,000, $2,000 from Eli Lilly or Novo. Like it was not crazy amounts of money. And I'm just like, come on, guys. Like that's like 1 or 2 months of medication to them. if you're going to sell us out and take away access to medication, you should at least get a new kitchen, right? It's honestly embarrassing that's all it cost. But honestly, some of the representatives, when I looked at their finance information, some of them did not have crazy campaigns. Like one of them had a $14,000 campaign that was a co-sponsor on the bill. So we're talking about very small districts where patients calling in can have a massive influence if they suddenly see their constituents engaged. Because why it's at the state level is because things move faster at the state level. Indiana's legislative session ends at the end of February. So if they get this through, it's going to go through fast. Like Indiana was introduced, it went to committee the next week. It went to committee again, was amended, went through. Like it's like literally moving so fast that if you watched the hearing and you weren't used to watching hearings, you would like blink and you're like, wait, it already got voted on. It's already out of committee. Wait, it's already like passed the Senate. Like that's how fast these things are happening because they know most people are not engaged.
So how did you get involved in politics? I mean, you must be involved in some degree in order to understand how all of this is working. No?
Look, a year and a half ago, I was working in video games, Amanda. There's no politics in video games. Nothing I did had anything to do with this.
Well, have you advocated for anything else in the past that had you on top of legislation?
I've done some mild advocating at the Texas state level. I will say I tried to pay a little bit of attention to politics in state. I think local politics matter. I would pay attention to stuff. But honestly, these are things I have not thought about since I was in high school, quite literally, to
Wow,
this
that
degree.
is so impressive.
Yeah.
Okay, so how do you know when these bills have come out? Is someone contacting you and saying, hey, there's a new bill? Or are you just trolling the internet looking for bills as they pop up?
Look, my content is a side hobby. I actually run a business. Look, there are some tools that help you track bills or help you service bills that exist. I certainly also use similar tools for lawsuits that are obviously different but similar. But also sometimes people message me. Like I've become friends with the people in the space who know me because they know my content. And they might literally be full-time in Florida. And so if I have a question, I can message them and be like, hey, how's it going? Or like, let me know when their committee hearing is there because I want to travel to go to the committee hearing in Florida. Stuff like that. So it is with the help of other people in the industry who happen to watch my content and let me know. But it is a lot of also me staying on top of things. Like I'm not like I might talk to like get one message a week, but things are moving way faster than that. So I'm staying on top of things. Like I'm looking at my other monitor and I have every single bill has its own like browser tab group where if I click on it, like 10 tabs will open of like background on the bill. Right? So like there's that. It's just organized chaos.
That's a lot. Do you foresee more bills popping up in different states then?
Absolutely. Absolutely. I've already heard of other bills being drafted.
Wow. Okay. It's really scary to think what would happen if just one bill passed, much less multiples.
Yeah.
What is crazy to me is that this is specifically because of GLP-1 medications. That's why it started. That's why it's spreading like wildfire. And that's what they're actually trying to target. That is crazy.
Well,
One drug or two.
it's not like in pharma, it was like blockbuster drugs were the big deal. Like, oh, you got a blockbuster drug, which is a drug that does over $1 billion per year. Now, like GLP-1s are not even blockbuster drugs. The industry is like expected to be over 100 billion a year, over 100 billion a year. So think about how much a pharma company will fight to defend their one big blockbuster drug and times it times 50 or 100, right? This is the entire thing. This is it. And these two big pharma companies, you know, they have history. Both of them did insulin. They call it a duopoly, right? Like a duo monopoly, where there's two companies dominating the market. It seems like that could be where we're heading again. And they have an entire playbook and scheme for keeping prices high. So not talking about Eli Lilly or Novo Nordisk, but I would say from a very, very high level, what I've heard pharma companies do with a medication like, let's say, insulin, you know, a medication people need to live, is that they continually release new versions of a medication like insulin. And there will be a viable version of insulin that they used to produce, and they'll be like, well, we're just going to stop making it. And because it's a biologic, which is like a more complex version, like not just a drug, it's a biologic, over 40 amino acids, it can't be compounded. I think about in the United States with how unaffordable healthcare is. We're like one of the wealthiest countries. We have people dying because they can't get access to insulin. They have to choose between heat in the winter and insulin, right? And it's super dangerous and it's unconscionable that we have people dying because they can't afford insulin. Because if you know the history of insulin, it was a patent owned by like the University of Toronto, and the creator of insulin tried to give away the patent for free. Like this should be free for everyone. Everyone should be able to make insulin.
Wow.
It is like a life-saving medication. And companies have come into the space and mastered the drug patent game. That, like, I think about it as like, and I'm not an expert on insulin. I don't know if it's how complex it is to manufacture it, but could you imagine if compounding pharmacies could make insulin safely? It would change everything. And
It's
that's what's
really
scary.
It's really, really interesting that you're bringing this up because I think you probably remember I helped the Institute of Medicine's Access and Knowledge connect with GLP-1 patients because they wrote a big report on GLP-1s and how it was similar to insulin.
Yeah.
And actually, they had a really big report back in the day for insulin and were a large part of why the price of insulin was capped at $1.35. They don't take a whole lot of credit for it. They're like, "Oh, we just wrote a report." But that report gave data to the people who could then fight for
Yeah.
access to this medication. And so they did the same thing with GLP-1s. They wrote this huge report about patent monopolies and how the drug companies will put patents on every tiny little thing, and they'll make these really cool pens that have all these itty bitty little parts that are all individually patented so that they could extend that patent out even longer. And then they'll come out with a new thing that it's FDA approved for, and they'll use the same drug, same
Mm-hmm.
exact drug, but they'll call it something different, like Mounjaro and Zepbound,
Yeah.
so that they can put a patent on that new medication even longer. And you're saying they could even drop the old one
That's what
and
I've
just keep
heard companies
extending.
do with insulin. I'm not saying they've done it. I'm just saying I've heard
Yeah.
companies do that with insulin. They'll just be like, well, we're not going to manufacture the old one. Of course, insulin cannot be compounded because it's over 40 amino acids, right? These can. Now, with their new medication coming out, retatrutide, there's a lawsuit that I think I thought it was going to get dismissed, but I think it's actually getting refiled or amended or like appealed. But retatrutide is 39 amino acids. If it's over 40, it counts as a biologic, cannot be compounded. And normal drugs under 40 amino acids, 7-year patent, I think, 6 or 7-year patent. Biologics, 12-year patent, right? So retatrutide, 39 amino acids, but Eli Lilly added on a few extra amino acids that were decorative. They didn't actually do anything to the medication. And so when the FDA categorized retatrutide as a drug under 40 amino acids rather than a biologic over 40 amino acids, Eli Lilly sued them. The last time I looked at the lawsuit, it was going to be, they were both going to withdraw and they'd come to some agreement, which I, being assumptive and being maybe pessimistic, is the FDA going to recategorize retatrutide as biologic? Because there are medications that happen all the time, and I'll give you an example. Desecrated thyroid hormone, which means nothing to most people, right? You're like, what the heck is that? It helps people regulate their hormones. If you've had your thyroid removed, if you have like Hashimoto's or thyroid cancer, it helps people regulate their hormones. And it is not FDA approved. Why? Because the medication has been used since before the FDA existed. And a lot of stuff like aspirin was not FDA approved until like 10 or 15 years ago. The FDA is, in theory, like a kind of young organization. FDA said, hey, you want to get this FDA approved, but we're also going to categorize it as a biologic over 40 amino acids, which can't be compounded. And people were getting desecrated thyroid. So naturally occurring hormones or peptides cannot be patented by drugs, right? So we see this whole craze with people doing peptides. Those peptides often can't be patented, which is why pharma hasn't done something with the peptides. So there are desecrated thyroid extracts that are naturally occurring that work better for people than synthetic versions that compounding pharmacies have been compounding. And I don't know actually how this resolved. I need to look it up. But like the FDA was recategorizing it as a biologic and requiring FDA approval. And what that was functionally doing is it was taking an affordable medication that people are getting through compounding pharmacies and removing access to that. And then giving a single pharma company who is seeking FDA approval for this, a monopoly on a synthetic version that wouldn't even work for a lot of people that were currently taking desecrated thyroid. And to me, that's tragic. You're taking a medication that is affordable and you're removing access.
Wow. Yeah, I had no idea that I've heard of like Avastin. I know that Avastin is being compounded. It's not FDA approved and they allow it because it had some incredible properties. I think it was keeping people from going blind and they were like, we need this. We're just going to let this be compounded. But I did not know about that one. That's really interesting. And that is really criminal. That's how I felt when I first found out about GLP-1 access potentially getting cut off. I mean, back when the FDA was talking about taking it off at the shortage list and we were all freaking out about what was going to happen, it's just absolutely criminal to me to hear some of these stories, people who have these life-changing experiences, not being able to walk without a walker and now running half marathons. The idea of taking medication away from a sick person who is now healthy it's just absolutely criminal to me.
Yes, but here's the positive, okay? I've probably said this to you before. I think we're at a really interesting point in time in the United States politically. Everybody. It's not a partisan issue. There's no disagreement between Democrats and Republicans. We all think it sucks, right? And we all know we're getting screwed. And I think GLP-1s present a unique period in time where we suddenly have this really unaffordable, inaccessible medication and people whose lives are changed by this medication, people who are now engaged in the healthcare system that have previously never been engaged in their healthcare, who are more willing to fight for access. And I actually think that's a pivotal moment in time where we have the opportunity to change healthcare for all of us because we all know it's broken. So I'm optimistic about it. Like, I'm not going to say I don't have days where I'm not optimistic. But the political engagement that I'm seeing around GLP-1s, where somebody has never contacted their representative before, and then I tell them about these bills and they contact their representative, suddenly they're engaged. And let's be real, our political situation is very chaotic. There's a lot going on. There's a lot that we all feel powerless about. But I think this is one area where we can change things. And politicians seem somewhat engaged on it.
Yeah, I agree. I mean, I'd never paid attention to politics very much, especially not locally. I mean, like you see stuff on the news and you're just like, "Oh, that sucks. Don't want that to happen." But like, what
Yeah.
am I going to do? I'm just one person. This is definitely the first thing that ever spurred me into action. And now it's like the rest of my life because
Yeah.
it's that important. I'm meeting all of these people who just started a medication and they thought that they were going to lose some weight. And now we're fighting for access and we're writing our politicians and we're blogging about it and we're going to events like Your Weight Matters.
Well, it's interesting because I think most Americans, like obviously politics impacts us all, but most Americans, like tangibly, like what feels like it directly impacts you quickly, politically, it's not that much. Most laws that get passed, like, yeah, they're going to have an impact on me. Like even the Affordable Care Act, that definitely had an impact on healthcare. But a lot of people did not necessarily immediately feel any impact or change from that. It was like really maybe like 10% of people that had very specific circumstances. Most of us, it's like the biggest thing that's going to impact our day-to-day engagement with politics is like, well, are my taxes going to go up? Right? Because that feels real of like, oh, I'm paying more. That feels real to us. But now suddenly we have people on this medication that has changed our lives. And the threat is we're going to take it away. And we're like, no, that is like absolutely real. Like that is more real to me than if I paid an extra $100 a month in taxes.
Absolutely.
Right? It is more
Absolutely.
than that.
I want to hear more about your background.
Okay.
Like, I want to hear about your journey from the beginning to now with your GLP-1. So you said that you originally were paying $500 a month.
Yeah, for compounded. It was like 550-ish. This is a while ago. So I've been on GLP-1s maybe 3 years now, which makes me kind of old, like an early adopter, right? An early adopter in the
You're an
GLP-1
OG.
space. OG, right? And what's interesting is, I'd struggled with my weight basically since high school. And I'd gained a bunch of weight. I'd lost a bunch of weight, kept it off for 5 years. I was like, oh, I've won. I figured it out. Cause like no one keeps it off for more than 5 years. I was like, I'm good. And then my dad got sick. I had to suddenly become his caregiver. And it was like suddenly keeping the weight off was not the most important thing every single day. And I gained all the weight back, basically. And so I tried to lose the weight again and it was harder. I counted calories for almost 6 months and it was like I couldn't lose more than 10 pounds and it was like something has changed in my body and my body is fighting this more than it did in the past. I had done all the research about GLP-1s and I was like, well, this actually does seem promising. I read a bunch of science studies and I was like, this actually does seem like good. Like it's not BS and I'm willing to take it. But I was like, but let me try on my own.
Yeah.
But
Yeah.
let me try on my own, like I know how to lose weight. Let me just like do it on my own. It's interesting because I think you mentioned like within the first month or two, I knew I was going to be on this medication for the rest of my life because it just changed the food noise. This thing that was like constantly actively going in my head, like this like little devil on my shoulder, obsessed with food, was quieted for once. And the journey was not easy for me because I get really bad side effects. I could not tolerate going up. I could not tolerate going past the second highest dose on semaglutide. Like that's how sensitive I am. When I went up to 0.75, I was throwing up 3 times a week. I was like, this is untenable. I have so many side effects. It's like tricky. Like I genuinely don't know if name brand would work for me compared to what I'm currently doing at compound because I am so sensitive to side effects. But even then I'm like 100% sold. This is like the most important medical discovery of our lifetimes.
Yeah, for sure. So when you say that you have really bad side effects, have you tried titrating more slowly than normal, or did you
Yeah.
go up every month?
Well, I started going up every month and then I could not tolerate going up. And so then I stayed on a lower dose and stalled out. And eventually it was like the hunger was kind of back because I was not at a therapeutic dose, but I couldn't tolerate a higher dose. In hindsight, now knowing what I know now, I would have titrated up slower, but that's not what I did because that's not what my clinician told me to do.
Right. Well, this is
Um,
3 years ago. We didn't
yeah.
even know.
Yeah. Now I'm on tirzepatide. I have significantly fewer side effects, but I still have a lot of side effects. It's still not easy for me. I'm not on the highest dose of tirzepatide. I don't know that I could tolerate the highest dose of tirzepatide, but I've also gotten better at managing side effects. And generally for most side effects, they do get better the longer you're on the medication, even if you're on one single dose over time. So
Yeah. With retatrutide coming out, are you curious to swap over to that to see if it has less side effects for you, or do you think you're going to stay on tirzepatide?
that's a great question because I wasn't planning on it. Because I think, and first of all, I haven't done enough research to make a decision because it's not FDA approved yet. So it's like that decision is in months and I'll look at the data when I'm closer to it being available. But my impression, having looked at some data, is that tirzepatide has potentially better muscle retention, which is important to me.
Interesting. Yeah.
I won't say never, like I won't try retatrutide, but I do think broadly retatrutide is like too much for some people. Like it's like they don't need that much weight loss. And then there's a lot of other people who are slow responders or they had more weight to lose where retatrutide is like going to be everything to them. I think it kind of depends on the person. I wasn't planning on trying it out, but like now that you mention it, I'm like, oh yeah, my side effects are kind of bad and people do get less side effects of retatrutide. Maybe I should try. You're like the only person that has brought it up where I'm like framed it in a way where I'm like, maybe I should.
I had no idea that you were having these side effects. I've heard of people just like being stuck in the bathroom, throwing up all the time, and how, like, yeah, I lost weight, but it was so terrible, I had to quit. I have not had that experience. I've barely had like the tiniest bit of nausea, maybe 3 times in the last year, but I took the tiniest little baby increases. I was on 2.5 for 5 months. And I was lucky because I came in at a time that we knew that personalized dosing is actually like should be standard protocol. It really should be. This is the first medication I think in the world that dosing is based off of how you feel today. How do you feel? How do you feel this week? It's
Yeah.
crazy.
Honestly, like it should be like really nuanced of like, how are you feeling? Like what outcomes are you getting? Like you should be having those conversations with your prescriber about
Yeah.
how to optimize your dosing. First of all, I'm jealous that you have far fewer side effects because I'm like a canary for nausea. I get so much nausea. When I was starting to build this, it was early enough that I didn't have a ton of friends on these medications. Like I was the only person I know. And I like literally went up to friends where I'm like, hey, I started taking this medication. You may have heard of it. Like, and then like no pressure, but like if you have questions or maybe you try it, like let's talk about it, like that sort of thing. But I spoke to one woman who was an earlier adopter because I think she had diabetes and Ozempic just gave her diarrhea. She literally like told me a story of how she pulled over her car and took a shit on the sidewalk because it was so bad. And she was on it for like 3 months, titrating as slow as possible, trying to like get it to work for her.
Yeah. I've talked to a few people who've had some experiences like that. I know there was one woman who was wearing a diaper, which is just, it's crazy
Yeah.
that this medication is so life changing that we would rather wear a diaper and take a crap on the side of the road than stop taking it.
I'll be honest, if I was shitting on the street, I I would consider if this is the best medication for me. But like it would still be a hard decision. That's what's messed up. It would still be a hard decision.
So, do you mind me asking? This might be kind of personal. Do you mind me
Yeah.
asking how much you pay on average for your medication now?
Oh, this is a hard question to answer because like I change providers every month, right? But I would say for tirzepatide, I'm often paying like $200 to $300. And because I change providers every month, I'm doing like monthly plans, which is more expensive. If you follow my content, I review providers every month.
I saw that. It's
Um,
very cool.
yeah, I try to do different providers. And then also like sometimes these telehealths are lying to us. And I like want to see what the actual process is. I've had telehealth be like, oh, we have comprehensive nutrition support. I'm like, cool, what is that? And they'll be like, it's an AI slop PDF that we email you. And it's like, I don't need someone to write me like 3 pages of bullshit on nutrition. That's not care and support. Some information, I guess, is better than nothing. But because one of the things we do at GLP Winner is we try to standardize the features of all the providers. Some of them, 100% of patients see an obesity medicine specialist. And to us, like, that's great. Let's highlight that. Some of them, you get a free dietitian along with your medication. And cool, like, that's a higher level of support than a PDF. So we try to standardize that. We try to help make it actually comparable because a lot of these telehealths are exactly the same and not at the same time. And it's so difficult to compare and figure it out. So that's what we do at GLP Winner.
I think that your tool is so incredibly needed. And I send people there all the time. Whenever someone comes to me and they're like, where should I go? I'm like, well, you should go make an informed decision with the data that is presented to you in an accurate way.
Yeah, and honestly, people ask me all the time, "Who's the best one? Like, who should I go with?" And honestly, I don't know. I don't know for
Go
you,
find
right?
out for you.
Yeah,
Yeah.
yeah, it's like, first of all, who's available in your state? Because like, somebody you're thinking of may not be available in your state. And then it's like, are you on maintenance? Do you have everything figured out? Because then maybe you look at price and what compounding pharmacy people are using. And if you're not, hey, maybe you need a provider with more support, right? It
Mhm.
depends. And I know a lot of people who maybe have been on the medication a year and then they decide they want a provider with more support because they lost the 15 to 20% and they're like, well, still need to lose more. So now I need to go to a BC medicine specialist. Now I want a provider that's giving me a dietitian and all these extra tools. It really is personal, person to person, what you care about. Some people, they want text only and they're like, I don't want to talk to a person. Like, I just want the minimum. And other people are like, well, I want a video call. I want to be able to like have extra visits with my clinician and ask questions. We have providers who do the whole spectrum of those things. So
Well, thank you for doing what you do. Thank you for creating that tool. And more than anything, thank you for staying on top of these bills and sharing with everyone what is going on so that we can actually take action.
yeah. And thank you so much for having me. And if you're listening and you heard about a bill in your state and contacted your representatives, thank you so much. I'm terrified of us losing access. And also, like, a lot of these bills are taking away access for all compounded medication, and that's inhumane. That's absolutely
Inhuman. If there was one call to action that we could leave the listeners so that they could take action if they live in that state where there is a bill, or if they don't live in a state where there is a bill that is being presented, what call to action do you have for them?
if you don't live in a state that's impacted, share it with if you have friends in the state that is impacted. And you can always call your reps about the federal Safe Drug Acts bill. I think Dave has also a petition,
He does. I've shared it.
the change.org petition on it. You can always be engaged in your politics and contact your reps ahead of time if you're worried that a bill is going to come. But let's talk through, particularly if you're in Washington, Florida, Mississippi, and there's also one in Massachusetts. If you're in those states and you don't want compounded access to go away or compounded GLP-1 access to go away, you can contact your rep. How do you do that? First of all, you can usually search like who's my representative at the state level, like look for your state name, like Washington State representatives. You'll put in your address, you'll see who your rep is. You can email them, you can call them on the phone, You can visit in person at the state capitol if you live close enough to the state capitol that you can do that. The in-person visits to their offices, even if you don't have anything scheduled, you just pop in, can be extremely effective. And you can also visit, if you're in a state that's not that large, their local offices are likely near your house if you're in their district. But like me in Texas with crazy shaped things, sometimes people are not near where the rep's offices are. So look it up. It will probably show it when you look up your rep. Now, what to tell your rep when you call. Tell them you don't like the specific bill. Give the bill number. We'll have the bill number in the notes for the podcast. Tell them your story. Your patient story as like a normal person has a profound impact. Talk about your access to GLP-1s, access to other medication you may be using that's compounded. Break it down simply. I think it's really effective to be like, people are accessing this medication. They will not be accessing this medication if this legislation is passed, right? Tell your story about how GLP-1s changed your life. Talk about what it would mean for you if you lost access. Would you no longer be able to afford it? Would you go to the gray market? Which was actually less safe? The Washington State testimony. We saw testimony from people from Eli Lilly and other places, and they were like, they basically said we're shutting down unsafe API manufacturers. And they were implying the gray market, but these bills don't do anything to the gray market. What it's actually doing, it's going to send people to the gray market, right? So if you lost access to compounded GLP-1s and you would maybe go to the gray market, maybe go without, maybe it would impact you, maybe it would impact your entire family, maybe it would impact your parents, your relatives, your best friends. Tell all of that to your representative and tell them they're making your healthcare less affordable and less safe and less accessible. Because if you don't have access to compounded medication, instead you start giving yourself medication with no doctor involved, there is something less safe about that. And that's probably, to the representative's credit, they probably don't understand that's what these bills are doing. And they probably don't understand that. They just read that it was a safety thing. And the more vocal you can be, the better. A lot of these, especially the House bills, House representatives, they don't get that much engagement. A lot of House districts in the state level are relatively small, right? So even if just 5 people call about a bill, suddenly this is something that people are really, really engaged on. So your voices matter. Everybody calling in Indiana got the bill to be amended so that it's a lot less of a crisis. And so just know if Eli Lilly couldn't get this through in Indiana, it's a great sign that we can have our voices heard in other states, right? And so whatever angle works in your state that identifies with it, you know your state best, right? This is a nonpartisan issue. Republicans are bringing these bills forward. Democrats are bringing these bills forward. And I hope it stays a nonpartisan issue, but at this point, it's an education gap for the representatives. Do they know if these bills pass that people in hospice will not be able to get pain relief at end of life? Like, do they know that? I don't think they do.
That's a really good point that you brought up. I'm thinking about how GLP-1s are getting attacked. I didn't even think about the horses or people in end of life care or the people who have other compounded medications. That is a very scary thing to think about. And I'm sure you're right. Our local reps very likely do not understand what they're reading, and they see Safe Drugs Act and they're like, cool, I'm making things safe. So yeah, we definitely need to call them and let them know in a way that they can understand more easily that this is affecting X, Y, and Z, and it is not what it appears to be.
Yeah. And I mean, if you are just full of time and proactive and you're living in a state where there isn't a bill, you can always call your reps and be like, hey, I want to talk to you about an issue I really care about, and that's compounded medication because it's changed my life. I would not be where I am today without compounded GLP-1s. Tell them your stories. Your stories are so powerful. And if you can go in person to their offices or in person to meet with them at their state offices, if the legislature is in session, that's super powerful. If they look into your eyes and they can tell that you're a real normal human who's from their state, who is being impacted by this, it makes a massive difference.
Oh, that's a really good idea. So you're saying that even if you don't live in a state that has a bill right now, that you should still be calling your reps to let them know how important this medication is and that you're maybe afraid of a bill coming?
You can. I'm not going to say that's an emergency. So if time is really tight for you, I'm not going to say like, hey, everybody, like my promise to people who follow my content is I'm not going to try to waste your time, right?
Yeah.
It's not an emergency if there is no bill. But I think if you are really scared and you have the time and you want to be engaged, you can totally bring it up as an issue. There are advocacy groups where they just go and talk about issues, and there isn't necessarily a piece of legislation to point to at the time. Now, it's more helpful and constructive if there is legislation to be like, oppose this. But if you live in a state that might be getting legislation soon or is having a legislative session soon, you can probably make a huge impact by going forward and just telling them ahead of time, hey, this is an issue that's really important to me. Hey, it's really important that you understand what a compounding pharmacy is and you understand that it's critical infrastructure for healthcare.
Before GLP-1s, people did not know what compounded medication was at all.
I didn't.
And now we're learning how important it actually is.
Yeah.
Well, that was great information. Thank you so much for sharing this and for giving us such a great call to action. And I hope that this episode really makes a difference for people and empowers them to take action.
I hope so too.
Thank you, Sabina.
Thanks. Bye.
If you've made it this far, thank you for listening and thank you so much for your support. Visit glp1studio.com to track the latest updates with these bills and subscribe to the studio newsletter to stay informed with big announcements. As always, I appreciate you and I will see you next time.
Prepare to be empowered.